Welcome to this morning's or this afternoon's webinar, wherever you happen to be. I'm Christy Sullivan, and I'm the Secretary of the American Society for Cellular and Computational Toxicology. This webinar is presented jointly by the ASCCT and the European Society for Toxicology in Vitro. Both of our organizations pursue educational activities, regular meetings, webinar programs like this one to promote computational and in vitro toxicology fields. We offer organization training and education and aim to support early career scientists as well. So the first thing I wanted to do is just give you a little brief tour of the Zoom webinar. In case you haven't been to a Zoom webinar before, you will be able to ask questions through the Q&A box. So you can click on down at the bottom of your screen, click on the Q&A and enter your question. We have two speakers today, and each will have a Q&A session after each speaker. So don't hold your questions all the way till the end. You can feel free to type a question as it occurs to you, and we'll ask it once the first speaker and then the second speaker finishes. You can also reach us in the chat if you have any technical issues. Then I'll turn it over to Anne-Marie Vingard to say a few words about ESTIV.
Thank you, Christy. I'm a member of ESTIV, which is a European pendant to ASCCT. And for those of you who are not familiar with ESTIV, I will give a brief update on our mission and activities. So the mission of ESTIV is to promote in vitro and in silico toxicology and to encourage research within the 3 Rs, and also to strengthen scientific networking of toxicologists. And the society is pretty active, I think. So we organize a conference every 2nd year. And the next one will be in Barcelona in November 22. And we also organize an applied in vitro toxicology course every year. And this year it'll be in October 21, and it will be an online course. And then we organize workshops and webinars like this one, and also give some poster awards at various conferences and meetings, and of course disseminate and communicate relevant information, mostly via our website. So if you're more curious about us, please visit our website or maybe even join us as a member. Thank you.
Wonderful. And it's really, this webinar program is a great demonstration of our two societies' joint activities. We have members of each society giving talks during, every month and participating. And so it's a great coordinated activity. Just a couple of upcoming reminders for ASCCT. This year is going to be our 10th annual meeting. It is almost always held in October, sometimes September. So it'll be in the fall of this year. And we're forming the organizing committee. So if you want to join and help plan the meeting and program, please feel free to email me. Also, we're taking a break from having a webinar in March because the annual SOT, Society of Toxicology meeting, is going to be sort of taking up a lot of days of, I think, probably many of you. And we are restarting again in April with a very interesting webinar topic, legal and policy considerations for use of new approach methodologies in chemical risk assessment. This is organized by some ASCCT members, and we're going to have two legal experts speak about this, and we'll have a really robust panel type Q&A discussion. So if you are interested, take a look at our website. It's not up yet, but it will be up soon for you to register and participate. And then finally, the last thing I wanted to say was we have a guide coming every year. The AICCT releases a guide to the Society of Toxicology's sessions, meetings, other events that are relevant to in vitro and in silico toxicology. And so we'll be sending that out to members soon, so look for that. And with that, I will start to introduce our speakers for the day. So the first speaker today is Ans Punt. She's a researcher at Wageningen Food Safety Research in the Netherlands. Ans earned her PhD degree in toxicology from Wageningen University in 2009 on the topic of physiologically based kinetic modeling. She's currently a project leader of several non-animal and international projects that focus on the use of PBK models in non-animal testing strategies and to simulate transfer of chemicals from feed to food. The goal for research is to improve the possibilities to develop PBK models based on in vitro and in silico input data and to increase regulatory acceptance of these models. And so she will be presenting a web-based toolbox to support quantitative in vitro to in vivo extrapolations. And then our second speaker, I'll go ahead and introduce him here now. Martin Scholze is a senior biostatistician and biomathematician with over 25 years of experience in the field of ecotoxicology, human toxicology, and epidemiology. He's currently a researcher at Brunel University in the United Kingdom. And his main research interests are the dose response modeling and assessment of individual chemicals and their mixtures, optimal experimental designs, test system development, and in vitro to in vivo extrapolation approaches. So Martin will be presenting quantitative IVIVE for predicting reduced anogenital distance produced by anti-androgenic pesticides in a rodent model for male reproductive disorders. So with that introduction, I'm going to give the floor to Dr. Punt.
Thank you very much for the introduction. Let me share my screen. So you are seeing my presentation, Christy? Yeah. Okay. So thanks again for the introduction, and thanks for having me here in this webinar on this topic of QIVIVE and the toolbox that we developed to do PBK model predictions for QIVIVE. So a little bit about my background. I'm from Wageningen Food Safety Research. We're a research institute in the Netherlands, primarily focusing on measuring and detecting substances in food and feed. So there's a lot of screening that we do, but we also look at the biological effects of chemicals and with in vitro assays. And an important step there is the extrapolation of these in vitro toxicity data to dose levels in humans. So at which levels you can expect these in vitro effect levels. So this is a topic that I'm involved in. So if we look at how PBK modeling is used in the extrapolation of in vitro assays, well, normally when we do risk assessment, or currently what we do in risk assessment, we extrapolate animal toxicity studies to humans. A safety factor of 100 is applied to account for species differences, human variation. And well, I think most of us agree that we would like to go more to mechanistic informations and to go to in vitro toxicity methods. But the extrapolation step to humans is a little bit more difficult. You need to know, okay, which oral doses would you need to reach these in vitro effect concentrations. And yeah, generally we don't have a lot of information about internal concentrations in humans. So that's why kinetic modeling plays an important role. So what you do with kinetic modeling is simulate what happens in a body and simulate plasma concentrations and then calculate back which oral doses you would need to reach these in vitro effect concentrations. So this process is we refer to as QIVIVE. Short introduction about PBK modeling. PBK models are computer models that simulate the behavior of chemicals in the body, how it's taken up, how it distributes to different organs. So in principle, PBK models always represent different organs. So you have the different organs of a body, a human, incorporated in a model, and in each of these organs, the flow of a chemical through these organs and what happens to the chemical is described with differential equations. So what you see here is an example of a differential equation of what happens to chemicals in the liver. The first part of the equation says, well, you have a change in liver amount of a chemical due to uptake from the intestine. So there's a fraction each time, with each time unit, there's a fraction taken up from the intestine. The level of chemical in the intestine will also increase due to it's taken up from the anterior blood and goes then to the venous blood. So chemicals go from a high concentration to low concentration in venous blood, and this is driven by the blood flow through the liver. And the last part in the liver is always metabolism. So the amount in the chemical in the liver goes down due to liver metabolism. So you see that how these differential equations are built up. Each block just represents, okay, what comes in, what comes out. And that's what you describe. And for the liver, you have various processes of various steps that come in or from different routes, and you have the metabolism that makes the amount of chemical go down. Whereas if you would have lung or adipose tissue, it's just going in and out. The key differences between these tissues is that in adipose tissues, chemicals will stick a little bit more, especially when they're lipophilic, than in lung tissue. So this is kind of the basic principle of PBK models. And if you integrate then these PBK models, you can simulate then all concentrations in these different tissues. So what input do you need to develop a PBK model based on also based on in vitro data? A minimal input requirements are liver metabolism. So practically every PBK model has a liver metabolism description in it. You need partition coefficients. These are then these factors that determine how much sticks to the tissue compared with blood. That determine that, yeah, it stays a little bit more in adipose tissue compared with the other tissues. You have the fraction unbound in plasma, and in case of oral uptake models, you need an intake parameter, how fast it's taken up from the intestine. So that's the absolute minimum PBK model. So that these input parameters you generally have in a PBK model. Now, for some chemicals, this is not sufficient yet. You can have metabolism in other organs than the liver, or you can have transporter-mediated processes. So when needed, you can adjust these models and these differential equations to really go, really adjust to the situation of your chemical of interest. And you can make it as complex as you would like or as is needed, particularly for transporter-mediated processes. These are more difficult to add to a PBK model, but sometimes needed when this has an influence on plasma concentrations, for example. So how it's used PBK modeling then in this extrapolation step of in vitro toxicity data. Starting point is always an in vitro assay, can be any assay, can be an estrogenicity assay, can be an developmental, well, it's a difficult assay maybe to capture in vitro, but yeah, and genotoxicity assay can be any in vitro assay. You start with an in vitro concentration response curve and you derive the effective concentration. And then with the PBK model you build for the same chemical, you predict then the internal concentrations that you expect at, for example, at the estimated oral dose levels, or and in this way you can calculate back which concentrations you need to reach these in vitro effect concentrations. And yeah, so this translation step you can do to humans when you develop a human PBK model, but you can also do that with for rats. So how does this work in practice? I've one example that I would like to show that we recently worked on. It's a case of methylparaben and different phthalates. These are food additives used mainly as antioxidants or as preservatives. What you see here, these are chemicals that really are structurally alike. So methylparaben and these different phthalates, they are structurally similar. And what we looked at here is the starting point is then the tox cost effective concentrations. So why did we pick these chemicals? Well, it's of interest to see that particularly propylgalate is interesting to see that it's raised concerns in the Netherlands last year, because if you look at the risk assessment, the current risk assessment of propylgalate, it's used in aqueous vitamin D droplets in babies and small children. But if you look at the in vivo animal data that is underlying this risk assessment, is not sufficient to actually conclude where it can be safely used, especially in this vulnerable group of small babies and children. And the reason is the developmental toxicity study that is in the regulatory file is just outdated, and it's not a good regulatory or developmental toxicity study based on which you can derive conclusions. So propylgalate recently has been discouraged in the Netherlands to be used at, it's not yet prohibited, but just discouraged that you cannot use it anymore for babies, really small babies. In case of octyl and dodecyl galates, these have recently been banned because there are not sufficient in vivo toxicity data to conclude on their safety. So given these caps in the in vivo toxicity data, it's of interest to see what you can achieve with in vitro data. So that's why we explored these tox cost effect data. So the AC50 values derived from tox cost. Well, I'm sure that most of you will be familiar with tox cost. So you have many in vitro assays representing different targets. And what is depicted here is the range of AC50 values obtained over these large range of in vitro assays. Highlighted in particular are the estrogenic activity assays. So there are all 4 chemicals appear to be active as estrogen agonists, or they had agonist activity. Though I have to say that the concentrations are quite high, 14 to 50 micromolar, and also higher than the cytotoxicity limit that has been set in ToxCast for these chemicals. So you can argue whether this estrogenic effect is actually specific. What we also saw, and that's the green dot here, so at much lower concentrations, you see the thyroid peroxidase activity. And this TPO inhibition was already induced by propylgalate at 0.58 micromolar. So that sounds like an effect that could more easily occur, but yeah, you still need to know, can these concentrations be reached in humans, and it's particularly also in children. In the graph, you see also some black dots. These are also AC50 values for active assays, and some are really at low concentrations. But further looking into these dots or these data points, revealed that these are actually false positives. So that there was no dose response curve or actually no relevant effect there. So particularly this TPO inhibition, and because thyroid peroxidase is important a target in the thyroid hormone homeostasis, it's important to find out if the oral exposures that we have can actually be reached or can result in internal concentrations that are comparable to this 0.58 micromolar. So that's why we developed a PBK model for these chemicals. So not only for propylgalate, but also for the different galates and the methylparaben. And we wanted to develop this very minimum model and see how that works out. And we did not only develop the model, we also built a toolbox around it. And you can access this through this website, QIVIVE tools.wur.nl. So, and the reason behind that is that I think with a toolbox, it's also nice to share how this works, because PBK models are always difficult to follow if you only see the model code. But this toolbox also allows for other people to work with it and to see how it ends up, or how you can predict plasma concentrations. So the toolbox is centered around this very minimal PBK model. Liver metabolism needs to be included, partition coefficients, the fraction unbound in plasma, and passive intestinal uptake. So if you look at propylgalate, I will just give the example of propylgalate all the time because it's a nice example. We gathered then information on to get these chemical specific input factors. And so liver metabolism, that's one of the first things that we always start with to measure. We measured it in this case with liver S9, human and rat liver S9. We did incubations. These are generally done by starting with 1 micromolar of your chemical, and then you look at the disappearance, how fast it is converted by the liver S9. And we added a mix of cofactors so that both phase 1 and phase 2 enzymes could be active in the S9. And we obtained an intrinsic clearance of, well, 428 and 818 microliter per minute per milligram of S9 protein for both rat and human. So that's one of the input values that you need. Another input values that you need are partition coefficients and the fraction unbound. And there are nice calculators for these. So you can do this with different approaches that are available. And we integrated some of these approaches in the toolbox. So the only thing you would need now is log P and whether it's the chemical is an acid or not. So the pKa values. And if you add these numbers in the toolbox, the partition coefficients and fractions unbound are directly calculated based on these available tools. I will show that in a minute. And you need then an intestinal uptake rate. You can measure that with Calco2 assay, so generally a PA/PP value. But in this case, we calculated the QSAR Calco2 uptake with an we used the QSAR to calculate the uptake rate and converted that to a unit that you can use in the platform. A next step, we didn't integrate this whole QSAR yet in the platform, but that will be a next step. So for now, the numbers in bold are the ones that you would need for the platform to calculate plasma concentrations. So I would like to switch to the QIVIVE platform. And I think you are all seeing it right now.
Yep, we can see it.
Okay, thank you. So technically, there are these boxes that you need that I've shown before. First, you add the physical chemical input data. The chemical had an pKa of 7.94. It was an acid, so you can have different selections here, but in this case, it was an acid. It has a log P of 1.87 and a molecular weight of 212.2. And this last step is important because if you want to convert in the end the plasma concentrations to micromolar. So you see that it automatically calculated the fraction unbound in plasma. So that's one of these input values that you would need. It calculated these partition coefficients that say something about how much it sticks to an organ compared with blood or plasma. In this case, you see that the partition coefficients are around 1. That means that there's kind of an equilibrium between blood or plasma in this case and the organs, the different organs. What you also see, you can add a blood plasma ratio of, well, in this case, I just assume it's 1. So then going to the next step, here you can enter this in vitro measured S9 clearance studies. It was 428 microliter per minute per milligram S9 for human and for rat 818. So this is the crude intrinsic clearance that you measure in vitro. that needs to be scaled, taking into account how much S9 is derived from per gram liver. So these are scaling factors that are frequently used in the literature, but you can also adjust this to your own scaling factor that you would like to use. An important step here is also to add how much S9 was in the incubation, because you get also non-specific binding to the S9, and this needs to be corrected for. So in our case, it was we had very low concentration of S9 in the incubations, and you see that there's most of it is free, so the correction is very small. So we've added then the liver metabolism, then the intestinal uptake, as indicated. That's also an important, and we calculated with these QSRs that these uptake rates are these values. The fraction that is absorbed, I just keep it as 1. So there's no, I don't expect any influence of that there's a reduced fraction of, absorbed. So then you can directly calculate, do a model simulation. So now focusing only on human, but you can also calculate for rat. And I would like to show a calculation of the oral dose in estimated oral dose for the use of this propylgalate in small in vitamin D droplets. That was around 0.59 milligram per kilogram body weight. So if I calculate then the concentration in the blood, and I have to convert it to micromolar, then you have the unit that is also present in your in vitro assay. You see that his oral dose that was estimated by EFSA leads to a Cmax of 0.06 or 7 micromolar. So that's about 10-fold lower than this 0.6 micromolar that induces TPO inhibition. So that can be calculated as well. So which or those would then lead to this 0.58 micromolar, and that will be, I've checked that before, of course. If I add a dose of 5.1, then you see that the concentration in plasma in humans is 0.58. So this is this concentration that is inducing TPO inhibition. So you would need 5.8 milligram per kilogram body weight for that. And a little bit less or a little bit more for rat, because the concentrations are a little bit less in rat. So this is how you work with it. So how you translate these in vitro effect concentrations. You just play around with the dose to see which oral dose results in these in vitro effect concentrations. Yeah, if I go back, oh yeah, there are various other options here. Maybe it's good to know you can also add a repeated dose so that there are more frequently a dose level. So yeah, you get more of a, can go to a steady state level, and you can also select different organs. So the concentrations in different organs. So going back to the presentation, I was here. So you see that these in vitro data and in silico data that we gathered, so it's only a few data points that you need to predict plasma concentrations of your chemical in humans or in rats in this case. And the most important one that needs to be actually measured is this liver metabolism study measurements, and the rest can be done with QSRs, although you could do that also, measure that in vitro. So what we've seen is if you play around with this oral dose, and we were looking for the oral dose that would result in 0.58 micromolar, because that was the dose that is the AC50 for TPO inhibition, you'd see that it's reached at 5.1 milligram per kilogram body weight propylgalate. So we've converted for all these ToxCast data to the equivalent oral dose levels for all four chemicals, and compared it then to this actually observed or predicted exposures. And what you see here is that the distance for methylparabene, distance between the actual exposure, so these are the triangles, the wet triangles. There's a huge distance between the actual exposures oral and the oral equivalent doses of these toxcast effect as data. So in case of methylbarbine, it's not very likely that you will reach these effect concentrations. So there's no concern at these estimated daily intake levels. In case of propylgalate, and that we saw already in the example, you're kind of relatively close to this oral dose that is equivalent to this TPO inhibition. So one of the highest estimated daily intakes. So this is for adults and both children and small children. That's all in the same. So that's why there are different triangles. But the highest estimates are only tenfold lower than this dose level that induces TPO inhibition. And in my opinion, that's kind of a range and that is quite low because you have all these uncertainties. So I do think this needs to be followed up. So can this TPO inhibition also occur in vivo, and can it lead to developmental toxicity study? It shows that it's it's a priority effect. In case for these two other galates, you see that the exposure levels are much lower again than the estimated equivalent oral doses for these different toxcast assays, including the TPO assay. So there it's less likely that you will lead to these effect concentrations. So based on this exercise, what you can conclude is that propylgalate is the priority chemical. So you need to, and it's relevant to further find out what this TPO inhibition is actually meaning. Or you cannot see the TPO inhibition as a replacement of developmental toxicity studies. So it's only a simple mechanism or target, and developmental toxicity is more complex. It might not one-in-one be translated, but it does show that these exposures are relatively close to this TPO inhibition effect data, and it needs to be further looked into, and that can be done maybe with follow-up, more complex in vitro studies. That will be in the ideal world, but if these are not available, then if you do in vivo toxicity studies, then this is an effect that you really need to have a further look at. And to check if this really leads to adverse effects. So this is the conclusions based for these four chemicals. So in the last few slides, I would like to also discuss a little bit how to go to regular acceptance of these approaches, these QIVIVE approaches and PBK modeling. So a key question that I always get is how good are your model predictions with these PBK models? And especially if you make the models only based on these very minimal input data. Now, in case of propylgalates, we had in vivo data, we had data in rat and human. So studies have been performed, kinetic studies, in which they've measured at different dose levels plasma concentrations. And so I've compared then this model predictions that I've just shown also with the toolbox with the actual measured observed plasma concentrations of propylgalate. And you see a couple of things here. First of all, if you look at the rat, the dots are the mainly the observed values, and this smooth line is the predicted plasma concentrations. And what you see is that the Cmax values are in the same line as the observed values, but it's the model does not capture the timing of the Cmax, so it's a little bit delayed in the model. Both oral dose levels, so both at the high and the low dose level. So it's not a perfect fit, but in our exercise we concluded, well, it's good enough because particularly the Cmax is adequately captured. And the same for humans. The dots are the individual human subjects. So you see there's a lot of human variation, and where in the Cmax, the majority of the Cmax levels observed Cmax levels are lower than what we predicted. But you see that there are two individuals that also have really high Cmax values, higher than we predicted. So in the end, we concluded, and the same here, there's lots of variation in Cmax levels and also in the timing of the Cmax. So we concluded that the model is sufficient to capture the Cmax of the chemicals, based on which we did the in vitro and vivo extrapolation. So in case of propylgalate, we had reference data or in vivo data to compare our model predictions with. But if you want to go to a future without animal testing, or and also a future where yeah, it's well for many chemicals difficult to also get human data or human kinetic data to make you model comparisons with. So if you want to move on with these in vitro based kinetic models, you need to find ways to validate these model outcomes without one-to-one comparisons to in vivo data. So we cannot do it all the time that if you build a model that you actually also have in vivo data to compare it with. So these are subjects that we're now picking up. So how can we move towards PBK model development based on in vitro and in silico input data without one-to-one validation against in vivo data? And two questions that we're working on right now is, so what is the quality of the in vitro and the silico input data? Because that really determines the outcome. If you have a poor quality input, you have poor quality output. And a key question that we always have is, okay, we start always with the minimal PBK model, but when do you need to include more complex processes? And currently we only can know that because we make comparisons to in vivo data. So if your minimal PBK model doesn't work, then you start adding more refining and adding more processes. So this is research that we currently do, and we did a pre-study for the OECD in which we looked at these in vitro liver clearance studies. These are frequently used as input for PBK models, and we did this in collaboration with RVM in the Netherlands and a joint research center. So this is work of my colleague Jochem Louise, who looked at the literature, and looked at, okay, what are the reported clearance values for individual chemicals and by different preferences. And you see that for each chemical, the reported clearance value can be over 1,000 or 100 to 1,000-fold difference. So this is on log scale. So there's a huge variation in clearance values, and you can imagine that it can also have a big impact on PBK model predictions if you use these different clearance values. So from a regulatory perspective, it's important to, if you want to accept PBK models based on in vitro input data, this variation needs to be reduced. And we think that can be achieved by setting up standardized or at least optimized protocols. And the last step that we're looking at is in a project, and that's with BASF and Unilever. We're looking at the predictions, or what if you use different input methods for PBK models. So you can use different calculators, you can use S9 measurement, you can use clearance data with hepaticides. So there are different approaches. What if you use different approaches, and what is then the range in Cmax predictions that you obtain? And what you see here is all again for a range of chemicals, the predicted Cmax versus observed Cmax. And again, due to the application of different input methods, you get a very large range. So this is again on log scale. The horizontal lines are the 10-fold range in which your model predictions, you would like at least your model prediction to be in. So you see that there's a huge variation due to different input methods that you apply. So we need to find ways of reducing this variation. Which input method is the best, or which you can will lead to better results than other input methods. So that's what we're currently looking at. And what we're also looking at, you see these light gray predictions. So these are chemicals that cannot be predicted with a minimal model. So the majority of the predictions are overestimated. And a key question that we have is, what are then the characteristics of these chemicals? And if you know these characteristics, then you can apply it also in the future as a tool to evaluate beforehand without in vitro, in vivo comparisons to find out if the minimal model will be adequate, or that you need to add additional processes, because it's clear that for these light gray chemicals, there's a lot of over prediction, so the model is not adequately doesn't needs to be extended to include processes to correct for this. So this is ongoing research. So I'd like to thank my colleagues for their contribution to this work, and thank you for your attention.
Well, thank you, Dr. Punt. I really appreciate your presentation. I also like the fact that you're looking not only at the science, but then thinking about how do we standardize and gain confidence in regulatory acceptance of these tools.
Yes, thank you.
So we have some questions coming in. If you have a question, please feel free to add it into the Q&A. So the first question is, let's see. Okay, in vitro effective concentrations were based on nominal concentrations. However, different chemicals distribute differently in vitro assays. Does your approach, or how does your approach deal with that?
Yeah, that's a good point. I now base the extrapolation on nominal versus nominal concentrations. So, but the in vitro concentrations, the ratio in free versus non-free or bound in vitro can be different than in the plasma. We now added the simple nominal versus nominal conversion in the tool. But for the future, we would like to add opportunities to calculate free fractions in your in vitro assays to the toolbox. So this is ongoing work. If you do the extrapolation based on nominal versus nominal, it's likely to be a worst case estimate. So in that case, yeah, you're looking really at a worst case. So I do think you can do the nominal versus nominal extrapolation, but it will be definitely better to refine this in the end. Yeah.
Okay. Is there a case where you might use CSS or AUC instead of Cmax as the dose indicator to compare between in vitro and in vivo?
Yes. Well, I think that still needs to be explored a little bit more when whether you do it based on CSS or AUC or Cmax. I think for these really threshold kind of effects like estrogenicity, I think Cmax is generally works out. Also, if you compare the extrapolation to actually measured oral doses in animal studies, so often it matches. But I do agree that in certain situations, when prolonged exposure is having an effect on the toxicity, so the toxicity is more due to prolonged exposure, then you need to go to CSS or AUC. But again, I think that's something that people do what they're comfortable with or maybe used to do. And I think we need a more general comparison of these approaches, and that's not available in the literature yet, to see what the differences are if you use one method over another. So there's a lot of research still that needs to be done to make this decision. Is it CSS, AUC, or Cmax that you do need to do the extrapolation on?
Yeah, okay. Let's see, in most of the in vitro assays, so the Tox21 data they're referring to, they used a 24-hour treatment. And they're saying in some repeated treatments, generally IC50 decreases after 24 hours. So the 10-fold margin of safety for propyl gallate should be higher. What? I don't think you're advocating a margin of safety necessarily. You're just showing the data, but
yeah, well, I kind of speculate about a margin of safety, of course, because I now say that it's 10, and yeah, I think that's part of the refinement as well. So this is just a very crude priority setting. So yeah, there definitely is something that it's relatively close, but how close we don't know, and that depends on these refinements. Yeah, and it relates, for example, to this point. Now it's only a 24-hour assay. So can you add a more sophisticated assay, or can you do a repeated exposure in vitro? So I think that's all for the follow-up, to see if you can refine it and to see to find out the true margin. But there are so many other factors that affect this margin. A human variation, for example. I've now done the calculations for an adult, whereas the most interesting case in this case is, of course, the child or the baby. So it will be also relevant to add human variation to the model. That also affects the margin. So it's difficult. Yeah, there's so many factors that affect the margin, this margin, but a factor of 10 is definitely something that you need to follow up on and do something about. If it would be a factor of thousands, I would not have worried. I would have left it as it is, but 10, you need to refine.
Mm-hmm. Here's an interesting question. How could the model be adjusted or applied for alternative routes of exposure? So inhalation or dermal.
Instead of intestinal. Well, that's well, we're looking that into these kind of the different possibilities for models. I say it with an EFSA project. So we're actually looking at, okay, if you can change things, but I'm not sure. We're not going to look at inhalation and dermal there yet, because food. Yeah, the thing is, food is mainly eaten. You're supposed to eat it and not inhale it. So because we're a food research institute, our primary focus is on food. But I do think it's again an important question, and I would like to add it to the tool at one point, even though we're not looking at inhalation or dermal exposure. But yeah, there are different projects coming up, and where yeah, definitely there's more research into that. Yeah.
Yeah, I think there are other tools that were developed, you know, for example, with the cosmetics industry in mind for dermal or yeah, so lots of tools out there. Okay, maybe we can squeeze one more in. How is the uncertainty factor calculated or integrated in the web tool? And I think they're referring to the, you know, I don't know, I guess sort of uncertainty factors related to different species or.
Yeah, I'm not sure if I get the question correctly, but I guess the answer would be there are no uncertainties around the uncertainties around the input are not incorporated in the outcome predictions. I mean, yeah, it's just the point estimates that you get from your in vitro experiment that you add to the model. So I'm not sure if these uncertainties are meant. So the uncertainties in the input, how it's propagated into the output, there will be a possibility to do that, but I think it's easy. I wanted to have the tool as simple as possible and just get people familiar with what kind of input you need to have. And I do think there are, when it comes down to refinement or more complex predictions, yeah, there are other tools to do that, or yeah, software packages where you can also add human variability, for example. But that's so yeah, with this tool, I wanted to just have a quick and dirty, okay, how does it work and how does PBK modeling work kind of yeah, tool.
Well, and yeah, and there are compliments coming in from some of the attendees.
Yes, thank you very much.
Right on the web, and people can go check it out. Well, we have a few more questions in there, but I think we're going to move on to our next presenter now. If you are able to type some of the questions while Martin is talking, that would be great.
Yep.
So Martin Scholze, please take the floor. You can share your screen.
Okay, I hope you all can hear me and see my presentation. I'm Martin Scholze from Brunel University, London, and I will guide you to our experience in developing an extrapolation tool, which started a couple of years ago, and which we think has some potential for regulation. The length of my title already indicates, referring here a very specific scenario. It's an extrapolation tool for predicting reduced anogenic distance produced by anti-androgenic pesticides in the rodent model for male reproductive disorders. So focus is really on rodents, animals, and not on the humans. So just before I start, all these more details besides my talk can be found in a paper published last year in EHP. And what I will show is present the outcomes from two projects, Punt and Janus. Both are funded by the Danish government and led by Anne-Marie Wingert. And whenever I will use the word we quite often, and it always means all the collaborators involved in this journey. A little bit about the background, why pesticides, as you might know. Nowadays, endocrine disrupting properties of pesticides must be assessed for the authorization in the European market, legal mandate. And we know from in vitro evidence and also in silico that many pesticides can antagonize the androgen receptor or inhibit androgen synthesis. However, most pesticides on the market have not really been tested for reproductive toxicity related to disruption of androgen action during fetal life, mainly because at the time they entered the market, there was no legal demand or no test systems available. This has changed, at least for the endpoints I will refer today. However, it means in practice that these toxicities will be conducted on developmental and reproductive toxicity studies, which are always not only cost demanding, but also animals. Many animals are required. And if I multiply this with the currently over 300 pesticides registered in the European market, you get estimates around 150 or even 200,000 animals required to do this work. So the question obviously pops up, do we need really the test? A little bit background about the endpoints they're talking. Androgens are key regulators of male sexual differentiation during the in utero or even early postnatal development. And we know now for a long time that exposure to chemicals that counteract androgen action at some stage in this period can demasculinize male fetuses and lead to male formations of the reproductive tract in later life. This has, on the bottom, you see in the table and figure from recent publishing by a colleague Christensen and all, which gives an overview about the adverse outcome pathways and male reproductive development. And why I'm showing this, two key events on molecular or cellular level, AR antagonisms and fetal androgen receptor synthesis, which both in an AOP context lead to one or adverse outcomes. This is called AGD, that's the anogenital distance. It's always good before you're starting thinking about in vitro and vivo extrapolation to have this mechanistic background, because then you're quite sure that you're on the safe code trying to link both. Moreover, if you go to AOP Wiki, you can also find an AOP under the development, which links AR antagonism with short AGD. So, what were the aims? First of all, the main aim was to develop in vivo to in vitro to in vivo extrapolation approach that utilize in vitro AR antagonistic and androgen synthesis suppressing properties of the chemicals in order to predict dose ranges for which shortened AGD in male fetuses can be expected in rodent studies after gestational exposure to pesticides. So this is a very specific problem we are facing here. And to do this, there was a second step required to develop a kinetic platform. And this meant in this case to develop a PPK model that simulates internal exposure levels in the fetus at critical time windows after repeated maternal nosing. So we're talking about a gestational PPK model. We had, unfortunately, not such a nice platform at that time available, and also no support coming from the in vitro sites regarding the kinetic model parameters required for the PPK model. However, we used a special situation of pesticides, because in the draft assessment reports, you can also find information about kinetic ADMA studies, which means where at least usually a low and a high dose tested either singly or repeated dosing scheme on animals and rats, adult rats, and then they measure on different time zones the internal exposures. This is, of course, an opportunity to estimate directly from animals, although adults and not the pregnant women, dams, the kinetic parameters of interest. Just very short to AGG, as you already expected, distance from the anus to the genitalia. Males has a wider distance than the females, and we know that if the short AGG is usually associated or can be associated with male reproductive disorders, ranging from poor semen quality to hypospadias, or even worst case to testicular cancer. In the rodent model, males have the size of the AGG in males is twice of female. And rodent studies, they're usually measured shortly after birth. We have testing guidelines, or testing guidelines have been adopted to this endpoint. So, and it has been also accepted as adverse outcome and test guidelines. So it's an endpoint of regulatory importance. Also, from we know from other reports or other studies that the most critical development period is beginning of the third week during pregnancy. It's gestational day 15 to 18. That's the time of the most sensitive time of the male reprogramming window. So from a modeling point of view, this is exactly where we need to focus on this time period in the fetus. Test system very shortly. We used, obviously, for the in vitro, this focus was on these two endpoints, and standard assays will be used to assess the anti-androgenicity or the testosterone synthesis inhibition. On the in vivo side, reproductive development toxicity is conducted. Important to know the gavage time, the exposure time, start in the second week pregnancy, so GD7 until to the whole pregnancy. Two different species were used, two different rats were used, Vista and Spratley Dorley. We used litter sizes of 6 to 11, sample size of 6 to 11 liters for the AGD determinations, and blood samples were taken always around birth. In total, 4 studies. Just coming to very quickly to the PPK model we used for gestational exposure. We used published model structures adopted mainly from papers from O'Flaherty and Emond, and slightly changed the structures. It was a very simple model, only the most important compartments, flow limited, only one intake route, only first order kinetics, and the fetus, due to lack of any information, support information, was considered only as a single diffusion limited compartment. The transfer between the two placenta units and the fetus was considered as bidirectional, and the main absorption was controlled via the GI tract. Regarding the kinetic parameters, yes, we used mainly for the main parameters like plasma protein binding or the partition coefficients, standard models and standard in public available tools. However, all the elimination parameters were directly estimated from ADMA data, in vivo data from the draft assessment reports. We faced, of course, a problem with the bidirectional exposure transfer rates between the placenta and the fetus. There are no tools available. And how we dealt with the uncertainty? Well, we used a worst case range of model assumption. So we screened the whole literature and collected all rates which have been reported, similar testing outcome, and also considered an imbalance between both rates of 20%. So we did not estimate a single value, but always a range of values. Furthermore, we didn't consider the peak concentration as relevant because due to the model structures and how we derived the kinetic parameters, we had not much trust really in the peak concentration, but in the area under the curve we considered as relevant, more relevant, and defined an average fetal plasma concentration as the area under curve for the relevant time period, so GD 15 to 18, and divided them by 72 hours. That was our pragmatic way to define and estimate an average fetal plasma concentration. If we're dealing with pregnancy, don't forget all the physiological changes which have to be modeled. So the parameters, key parameters relevant for the kinetics like blood and tissue volume and blood flow rate changing over the time. This is documented here in the two figures. The red area illustrates the exposure period. And as you see, all these are derived from publication and will modified if whenever possible by our own data. So they're changing, some of them changing dramatically, obviously. And these models were also included in our PPK model. So how did we develop our in vitro to in vivo extrapolation approach? We defined 3 stages. The first stage, we checked the general applicability of our approach by using focusing on through well-studied anti-androgenic compounds, including linorone and prosimidone. Well-studied means here that we had in vitro and in vivo data, which clearly showed anti-androgenic action in vitro and a shortened AGD in males. So this was used not only to check the QIVIVE, but also to adopt our PPK model structure, whether it will make sense at all or not. Second stage, we applied the whole approach to 9 current use pesticides, all with in vitro evidence for anti-androgenicity, but missing in vivo confirmation. So here we ask the questions: can we use it? Can we use this to anticipate in vivo effects? From these 9, we selected 3 and went with them in the in vivo testing to confirm our expectation of a shortened AGD. So the first step, the first stage, these are the 3 compounds. On the top panel, you see the in vitro evidence. On the bottom, the in vivo data that collected. Most of them have been published or they were generated before we went into this simulation, PPK simulation. On the top, you see also another androgen steroid hormone, blue colored, which is not relevant in the beginning. We also measured this, but then it was dismissed in all the decision process. So please focus always on our antagonism data curves, red colored, and the blue color, the testosterone inhibition. On the bottom side, the in vivo data for the AGD. And probably most of you are not very familiar with this endpoint. It's a morphometric endpoint, so you have always to consider the body weight of the pup. And this is usually expressed via the Anogenital index, which is simply the distance, AGD distance, divided by the cube root of the body weight. And you can even further normalize this to a scale between 0 and 1 or 0% is 100%, with 1 referring to the male controls and 0 to the female controls. So this is a maximum range, you can say, for phenotypic feminization of the male pups. Okay, so how something to consider, which is important, are the metabolites. In the usual animal testing, we have never really the certainty whether the parent compound was responsible for the toxicity observed or not, unless we measure this. However, in the modeling and PPK model, this is essential to consider and to reflect whenever these compounds are capable to provide, in our case, androgenicity in vitro or not. Ignoring this will most likely result in false negative decision. And this is obviously a complication, always a complication if you have this case. In Linearon here, we had to deal with 2 metabolites, which were anti-androgenic. Vinculosity, we faced a similar scenario. It means always a complication for the PPK model, because you have to build up a second layer on the third layer for each of the metabolites on your structure, which focus on the maternal compound. And each layer is connected, usually in our case, only by 1 parameter describing the conversion from the parent compound to the metabolite, or from the metabolite here to the next metabolite. So we went and testing just to confirm the internal exposure levels. Here you see the results for 3 compounds. The red bars are the simulated plasma concentration at the end of the pregnancy at GD21, and for the DAMs, and more relevant for the fetal concentration at GD15, GD18. The black dots refer to the measurements. In this case, also the internal exposures in amniotic fluid was measured, which we didn't consider in our PPK model. So we can quite interested in, does it matter how big are these concentrations, how large is this concentration? If we start on the left side, prosimidone, generally a very good agreement between our simulations and the observations. Please keep in mind they are not directly comparable, because first of all, that for different time points, the simulation referred to the GD measurements in pups from GD15 or GD18 age. But we measured this in GD21, but we don't expect a big difference between this. The second point is how I defined the simulation, the average concentration as a average based on the whole area under curve. But obviously the measurements refer to a certain time point. This is around 90 minutes after dosing. And we think in most cases it's probably after the peak, shortly after the peak. So for prosominone, good agreement. Vinclozolin, in principle, yes, regarding the two metabolites. However, the parent compound couldn't detect, neither in the dams nor in the fetuses. And linarone, also a very nice agreement on both sides, the dams on the fetus. So we were quite pleased this worked. Now coming to the extrapolation. What you see here on the top panel, again, the in vitro data. On the bottom, the in vivo data. And in the middle, the link. How can we read this? First of all, we see the dots. Again, these are the measurement, which we have just seen before. This curve, this shaped curve, if we focus on the left panel, the proserpine zone, red colored, these are the simulated fetal levels. It depends on the dose. As I said, we are always simulating range, depending on the worst case scenarios between the transfer between the placenta and fetus. So this is not a single value, this is a range. Horizontal lines refer to potency value from our two in vitro endpoints. Vertical lines are derived from the data, vivo data from the bottom, and these are the benchmark concentrations. And what we want is really a good overlap between the doses which are associated with fetal conscience, which are the dose levels, which are leads to fetal concentration, which are associated with in vitro activities. And we will look here. This would refer, if we use an the EC50 as marker, to range between 10 and 17. And if this is exactly the area dose range where we observed the in vivo effects. So here we have a clear correlation. If we swap to the right to linarone, here it's a little bit more difficult because we have not only the parent compound, but also the two metabolites. All were tested, as seen in the top figure. And if we look here, first of all, here we studied not only one dose level, but the three levels. So we get a confirmation of a wider range of the wider dose range regarding the agreement between what we simulated and what we measured. And we were also here quite pleased. There's a good overlap. If we start looking on the comparison between the in vivo dose range and the in vitro dose range, or the expected dose range with in vitro activity. If we focus first of all on the parent compound, linarone, it's the red colored. Here we would expect at very high constant dose ranges only the relevant impact. So this is not really clear agreement to the. We're talking about 100, 100. So we don't know. It might already be in the maternal toxic ranges. However, if you're focusing on the metabolites, for example, the green lines or the blue lines here from the two, compared to the crossing point to the EC50 activity and going down, this falls all in the range where we observed in vivo effects. Similar picture is vinclozolin, but a little bit more complicated because we couldn't detect vinclozolin. Further on, one metabolite is not very potent, it's clearly outside the range where we observed, outside the dose range where we observed in vivo effects. However, on other metabolites, it's different. And here we have also a relative okayish agreement to the dose range for our endpoint, in Vivo endpoint. So we came here to the conclusion regarding the PPK model structure. The individual measurements were in all cases close to the range of the simulated factor 5. Exception was the parent compound vinculosity. So we came to the conclusion, okay, we can use the PPK model structure, we can go on. Furthermore, the doses simulated to be associated with in vitro AR antagonism and endocrine synthesis suppressing properties overlap relatively well with dose ranges at which shortened AGD in male fetus observed. So we came to the conclusion, yes, our in vivo exposure worked. Some comments here, what was the most critical parameters in our kinetic simulation were first of all the metabolic conversion from the parent in the to the metabolite. So if we got not the simulation for your parent compound correct, then you're very likely that in danger that you miscalculate, you missimulate also your metabolite. It's a typical case of an error propagation, which we fear most in the model world. So here you must really be very sure to get the right value. Furthermore, as I already mentioned, the bidirectional fetal placental transport is a key parameter, which is not very surprising. And that's also the reason why we always use this worst case range of possibility rates. Second stage we entered, so the focus, we collected 9 current-induced pesticides, mainly based on a publication 10 passed from 10 years ago, I think it was, where we not only tested a huge range of compounds on their potential AR antagonist properties, but also ranked them to the crude exposure likelihood in humans. Common to all pesticides was we had no idea, no evidence from in vivo studies regarding their male reproductive health. Here, okay, we went with these 9 compounds in simulations, in the kinetic simulations. And I will now guide you through one example, fluodoxonil, how we assessed the potential anti-androgenic effects in vivo. 2 steps. First of all, we estimated the dose expected to produce fetal levels that are equivalent to in vitro concentrations associated with a certain potency regarding the AR antagonistic activity testosterone inhibition. And here we went for 20%. We don't know really whether 20% is sufficient or not. So it's a pragmatic solution. So we ruled out any lower activities as relevant in our decision tree. Furthermore, we also were obviously interested in the high dose, the maximal dose of interest. And here we used the expert all evidence, especially from the draft assessments regarding toxicity, cytotoxicity, unwanted cytotoxicity, which we wanted to avoid in the testing. This is illustrated here on the right side in the graph with the gray bars. With a dark gray, that starts always refers to the where lowest observed effect level has been reported. So the dose with a confirmed effect, unwanted effect, and the start of the less gray bar indicates the reported no observed adverse effect level. So the darkest gray areas we wanted to avoid, and here in the gray area, we were not always sure whether we can really rule out, but this was accepted. So in this case, if we go using this definition, first of all, if you're looking at the crossing, it's around 20%. Here we would start, here we would thinking that the in vivo to in vitro explosion cannot rule out reduced AGD. And probably here around 180-20 as a maximum dose. This was done for all 9 compounds, but before we filled the gaps on the vitro sides, we had only the data from for the AR antagonism, and here you see the results. And again, please focus on the testosterone and the AR antagonism. The gray areas indicate the cytotoxic areas. And just a quick look, you see the patterns are quite diverse. The profiles, so sometimes the AR antagonist is more potent parameters, and sometimes the other endpoint. Coming back to the simulation outcomes, here you see all 9 compounds. Starting with fluodoxanil, as already introduced. Here we clearly expected a potential reduced AGD. The similar picture was also decided for cyprodonil, simply because of the really high potent testosterone inhibition we observed. And if you compare the crossing, I mean, this was right below what we simulated. Nominal concentration range is well below 1 micromolar. On the other side, if you look going down to, for example, gamma silyhalosylene, oops, sorry. The plasma concentration simulated and the dose range were definitely too low to reach any activity, in vitro activity. Furthermore, also this is a dark gray market. We are not interested in this dose range because they will report other adverse toxicity. Similar for the compound on the right corner, pyrimethamine. Here we also came to the conclusion the fetal levels are probably most likely too low to reach levels that where we could expect any potential reduction in the AGD in the study. From the 9 compounds selected, what the downside is the uncertainty behind, and one compound was flagged from the beginning as the most uncertain compound. This was imazolene, mainly because the draft assessment reports provided not necessarily the information we wanted, and also because of the very complex metabolic elimination pattern. I will come back to this compound at the end of my presentation. So we selected 3 compounds for testing, for confirmation. These were fluodoxanil, dimetamorph, and cyprodonil. They were selected mainly through the different in vitro profiles. In the first case, both potency were quite in the same concentration range, where for the other, there are quite differences. The doses, the test doses were selected according to our expectation. 20 for fluodoxanil. We expected the potential of a beginning reduction in the AGD. The median dose was always selected where we had the highest hope to see something. In principle, also for the high dose, but we were not sure whether this might interact or interfere with unwanted side toxicity.
Pardon the interruption, Martin. We have about 2 minutes left.
Oh, okay. So very quickly, we made, first of all, we tested also the internal concentration. We saw again a relative good agreement. And then the test results, first of all, for fludarabinol and cyprononyl. The star indicates a statistical significance, and as expected in both compounds, the median concentration, median dose provided a clear reduction in AGD in male offspring. However, both the high doses were rather unclear. We speculate in the fludarabinol case that the high variation prevented the statistical significance, and cyprononyl probably the liver toxicity interfered. In case of diametamorph, on the left side, the outcomes from the main study, both too low doses, yes, produced significant results, but not the high dose, which was quite puzzled about this results, and which led to follow-up study on the different spectral types in this case. In this case, we confirmed the significance, but at higher doses. And similar to the previous two compounds, we came to the conclusion, yes, this compound can reduce AGDs in males. So this is an ovary. So on the conclusion is, first of all, the PPK was quite good in predicting really the fetal concentrations. The ratio between measurements and prediction was really around factor 2. We had some exceptions. This was, for example, the maternal plasma levels predicted for diametamorph, so 2 times lower than the analytically determined concentration. We speculated this refers probably more to the peak concentration. We can confirm that our approach identified 3 compounds as Vivo anti-androgens. Nevertheless, we had observed also that the in vitro active dose ranges of test compounds tended to be lower than dose ranges associated with shortened IgD, and we think it's the general problem of using nominal concentrations as reference and not really the bioavailable in vitro concentrations. Short remark to potential false positive reaction and why I mentioned the uncertainty behind our simulation for another allele. We were at the time not aware about a research project called Euromet, which developed a general PPKMA for adult rats, where they extensively studied the kinetics in vitro from evaporators and silico tools. So we used these parameters, the kinematic parameters, and came to much lower simulation results, which meant for these compounds, we would come to the conclusion to rule out a potential in vivo effects. And this is just into this was also tested by GTU. And here you see also a nice agreement between the measurements and our simulations. And this just highlights that's not always it was possible in our case to use really the information from the DAR reports for the estimation of the elimination rates, but also to use all available data possible. Remark regarding false negative prediction and how to interpret this. We should not ignore the fact that more than the processes leading to the sorting engine, which we used here, might induce shortened AGD. We don't have the whole AOP network behind this in vivo endpoints, so we focus on some parts. And this means we cannot rule that other processes might produce shortened AGD. This is, for example, in case for paracetamol, where we know that these substances are not capable of antagonizing AR or suppress androgenicity, so that's a clear warning. And just a big thank to all the people involved in this work, and mainly directed to the fantastic team of the Technical University of Denmark, comprising all the experts from the in vivo side, in silico side, the chemical and the chemists. And to my colleagues, thank you to all the people otherwise involved, technical staff. And just finishing now, thank you for your attention.
Wonderful. Thank you very much for your presentation, Dr. Scholze. We have one question come in so far, and so I'll ask it now. So thanks for an interesting talk. To what degree can this model be generalized to a broad range of compounds? And do you plan to make a rat to human extrapolation? So I guess that's questions.
Yes, I mean, the first question refers to the applicability domain, which is obviously a crucial factor. And I would say in principle, of course, it can be also used for non-pesticides as long as this simplification be used in our PPK model are justified. The applicability domain is so far not really well defined. Imazali is a good example that's really required. This work needs to be done. The problem is we are using many estimation tools for the kinetics, for example, and each of them has in principle its own applicability domain. So we have to consider different applications and also the uncertainty behind the whole structure. So in principle, yes, it can be done. Regarding the second questions, extrapolating the whole idea to humans, yes, it's of course should be a priority. But I am not sure whether whether we not need more and more complexity regarding the fetal compartment. I think I see really here the need to do this, and also the problem how we populate all the kinetic parameters required to describe more kinetic complexity in the fetus. But this is yes, this is on the agenda, definitely, to do this. Obviously, we have always here the problem of the confirmation of internal exposure levels. This is difficult topic, difficult issues, at least if it comes to environmental chemicals. But this is, yes, something to do. We are working on this.
There's always something to do. Okay, well, thank you so much to both of our speakers for your time and preparation and for telling us about your work. Thanks to all of you for attending and for your attention. And we'll say have a good evening until next time. Thanks very much.
Thanks.
Bye. Thank you.
Bye.